Good evening, ladies and gentlemen, colleagues and friends. Welcome and thank you for joining us this evening to our Sydney Prosthodontic Group webinar on the topic of improving ceramic restorations. Joining me live this evening are my friends and colleagues, starting from my left side here, Dr. Agnes.
Hello.
Dr. Johnson Chou. Hi. And our latest addition to the group, Dr. Zoe Potres.
Hello.
Zoe has just joined us over the last month or two at the practice, and of course tonight she is one of the panelists. So as you know that this evening session is live and interactive, so please feel free to key in your questions this evening, and I'll try my very best to put forward these questions to the panel to answer whatever questions that you may have. My apologies in advance if we are not able to go through all the questions, because sometimes it does get a little bit overwhelming with the number of questions. Tonight's session will run for a good hour and a half, and you shall receive your CPD certificate at the end of the webinar over the next couple of days. If you choose to receive that certificate, please put in your details at the bottom of the screen or the page that you're on. So it is a separate registration to what you have already entered in able to view this webinar. And again, I will remind you of that throughout this evening. Of course, these sessions are not possible without our sponsors. Firstly, Noble Biocare. Many of you guys have already known that Noble Biocare has been a sponsor of mine for about 10 years or so, and being in the leader of the implant industry. Once again, they are going to release their latest implant, which is called the N1 implant, very soon to the Australian market, and they will be challenging revolutionizing, I think, the way that we view implant surgery and also the way we restore implants with new connections. So we look forward to that new product. Our second sponsor for the evening is Biocredible. I'm sure you guys all know Sandy and Teresa. Now perhaps it's the better time than ever to secure that really low interest loan to carry out those renovations in the practice. Our third sponsor is by Kerr. Of course, it's very much a household name when it comes to endodontic and restorative materials. Particularly for tonight's session, we're going to be talking about bonding a lot. So whether we talk about 4th, 5th, 7th, right up to universal adhesives, Kerr has always been there with these products. So we certainly will be covering all the different classes and their strengths and weaknesses. And last but not the least, Experian Insurance Services. As you guys may already know, that during the COVID period, it's very much a trying time for the whole entire insurance industry. So there's going to be a lot of changes coming soon, particularly starting from October onwards, where some of the previous policies that we enjoy for granted will no longer going to be in place. So if you don't have the necessary cover or you haven't had your policies reviewed, now certainly is the time. And Mark Sachs is the person to go to. I think recently I was just being told in a story where a dentist over the last 6 months has discovered he had developed contact dermatitis, a very severe allergy, and he's tried all the different gloves under the sun and he's still getting a very severe allergy. So that has unfortunately stopped him from being able to work. Unfortunately, he has that policy in place. So yeah, so it's time to look into those things. You can never be too sure sometimes. Now, if you're joining us for the first time, just a little bit about ourselves. Sydney Prosthodontic Group. We're of course a prosthodontic group that's working out of Chatswood and Sydney, and we do share our offices with our endodontic and periodontic colleagues, where management or treatment planning of complex cases becomes that much easier. Not only is it a great learning method for us to always be able to speak to another colleague and get another perspective, but also it's a great value added to our patients who can very quickly get a second opinion. Collectively, at the 4 prosthodontists that we have, we are able to provide you and your patients a full range of restorative and implant surgical services. We're proud to be able to share information like this to you, our referring dentist, as a result of treating your patients over the years. Over the past 10 years, we have delivered over many hundred hours of CPD. So if you have missed any previous webinars, you can go onto our website, www.sitpg.com.au, go to dentist and resources, and there you'll be able to catch our previous topics and webinars. And if you do have any questions about whether it's patients related or any difficulty that you're going through, collectively with our resources, you are able to reach us, and we are here to help. So don't hesitate, because we often do receive phone calls and asking for advice on how to get out of certain difficult situations when treating patients who are, say, disgruntled, or there are certain clinical issues, whether it's again treating a patient or dealing with certain staff and employees. We certainly have heard a lot of those issues over the past, and we're able to help you with that. So let's get on to the topic of tonight. We are here to talk about ceramics, and we all use dental ceramics, and there are many different types of brands of ceramics out there, of course, released by a variety of different companies. And that's part of the challenge sometimes, is that because that we all want an aesthetic and durable restoration, and therefore it is a big market, and that's why these manufacturers are constantly releasing better and newer generation of materials. So it can be quite confusing knowing what perhaps is the most suitable ceramic for that individual situation. The other complexity with that is the different type of actual chemical or physical structure, what is contained in the ceramic. And then on top of that, these ceramic materials are made in different methods. And when you start combining all of it together, that's when it could become quite confusing. So sometimes some colleagues may simply prescribe that or leave that decision-making process to the ceramist. You know, they may say, look, this patient wants an aesthetic restoration, therefore I would like to prescribe an all ceramic restoration. But that term all ceramic alone could mean a lot of different things. Are we talking about lithium disilicates, or are we talking about zirconia, or are we talking about monolithic, or is it layered? Because that ultimately would make a huge impact on your clinical outcome, whether it's aesthetically or physical, mechanical properties wise. So I feel that as a clinician, we should have a very good understanding of this and be able to discuss this with our ceramists, in able to reach the best result for us and for our patients. So that's why we really want to explore this topic in detail tonight, to demystify what's out there, and also to look at the various bonding protocols, whether we talk about for enamel or dentine or whatever ceramic we're trying to bond to. So we'll try to ambitiously cover all of those topics tonight. So let's take a quick look into the whole range of dental ceramics. Of course, there's many different ways to classify ceramics, but this is one of the ways, which is on the left-hand side. You've got something that's primarily glass-based. On the right-hand side, that's primarily crystal-based, and then some combinations in between. So if we're using this as a concept to divide the different ceramics into different categories, then you could potentially split it into 4 different categories. So let's look at category number 1, our glass-based ceramic. As we all been taught at undergrad schools that feldspathic porcelain could be, or feldspathic porcelain veneers could be very aesthetic because they're quite translucent. So this is a material that's primarily made out of feldspar, which is glass, with very little or some amount of crystals. Because the fact that there doesn't contain a lot of crystals, so therefore they're reasonably translucent, and that's why they could make these things into very thin restoration and very aesthetic restorations. Depending on the amount of leucite crystals that this ceramic contains, it could either become your first group or your second group, just depending on the amount of crystals that there is. But primarily, this material has a glass matrix. So, Agnes, how are these things made by the ceramists, and is there a protocol that you could share with us into how to maximize bonding of these restorations.
Okay, thanks, Ben. So let's take a look at how we work with feldspathic porcelain first. So as Ben had mentioned before, feldspathic porcelain is primarily a glass-based structure. It may contain anywhere up to about 45 or 50% of leucite, but it doesn't have to contain any leucite crystal at all. It's like non-crystalline. And therefore, with that amount of quartz, it is enabling those translucency properties. But at the same time, we have to remember this restoration, if we're talking about, for example, feldspathic porcelain as a form of restoration, they are very, very thin in section. The whole aim is to be able to prepare or almost prepless or just a very fine preparation. And just triggering some thoughts here, normally we would prepare only 0.3 or 0.5 millimeters in depth and still within enamel. So these restorations are very, very thin. And of course, therefore, we need to bond them onto sound tooth structure for support. Bearing in mind, though, this feldspathic material and this form of layering I'm about to go through is also by the same principle when you order porcelain fused to metal crowns or porcelain fused to zirconia crown, that veneering porcelain that they put on top is also in this class of feldspathic porcelain. So essentially, if you have a look at the slide here, you will see that in your laboratory or your ceramist laboratory, they have some glass powder in front of them. And these particular different powders will pertain the different opacity or color tones or what they have to work up as a recipe to come up with a restoration, not only what you prescribe as a final result, but to consider what is the stump shade underneath so that add-on the restoration is the color of your prescription. And what they will do is they will pick it up with a paintbrush. They will then dip it into liquid to form something like, when we work with Duralay, that kind of consistency. So they start layering on the dye preparation that they've prepared. And it looked moist, just like on the photograph here, just prior to firing. As they build the contour, they put it into the furnace and they will fire subsequent layer. And after which they will come out in a hardened form. And here you begin to see some of that quartz quality coming through. And quite often the ceramists will then have to put in the features that they like to form, and they can now use a burr to do some tertiary anatomy or some refinements before they finally finish with a glazing into the restoration that you see in your hands when they complete it. So this particular case is one example of how we had managed, Dr. Lee had managed the open embrasures with feldspathic porcelain. And if you have a look in this particular case, where you really just after some form transformation on that labial surface, as well as the cervical proximal contour. And typically, we're not after a great change in the shade because we do have to consider that the stump color of this tooth will come through. So when we get our restoration at hand, first it appears like this on the fitting surface. We will then, after trying, as we're preparing the tooth for cementation, we would etch this fitting surface of the tooth with a hydrofluoric acid, 9.5%. Now, depending on the type of ceramic material, there is different recommended protocol or the time frame of etching the ceramic. This particular ceramic restoration being feldspathic, which is on the extreme end of having a lot of glass infiltrate that we can etch and create the micromechanical retention, we can etch this particular type of restoration for up to 60 seconds and then wash and dry very thoroughly. And after the air drying, you can now see that frosted appearance. Now, if your restoration already come to you already etched in the lab, it is important to know that as well, so that you know whether this particular phase is already been done, and whether you and then to consider how to prepare this surface after your try-in. So here in the electron micrograph, you can see that the feldspathic porcelain before etching is relatively smooth, but after the etching process, these are the micromechanical retention form we can create before we apply the primer. What the primer does is that it is able to infiltrate all these micromechanical crevices that we have etched the glass out of this structure. And then it also gives it a better affinity to the resin cement we are about to use. So that is what helps to create that special bond against the ceramic structure. And the primer often couples with a silane coupling agent, and some of the ceramic primer have other additives to it to increase this potential. After the primer goes on, we lightly air dry it, and we are now able to cement the restoration. And as we do the cementation for feldspathic porcelain, it is recommended that we use only a light cure resin, not dual cure, only because we do want to aim for a bit more color stability that is offered by our resin cement, and have that stability in dual cure resin cement, because half that setting reaction is with the chemical base. So it is more prone to having a bit of discoloration as that quality of the cement underlying changes. So,
thank you so much, Agnes, for a beautiful summary. Now, if you're just joining us live, please don't forget to send in your questions, and I will try my very best to direct your questions to the panel at appropriate times. And I'm sure we all remember that bonding feldspathic porcelain ideally is to enamel. And well, not just feldspathic porcelain, like it's composites or any structure for that matter. Johnson, could you go through with us perhaps how do we most effectively bond to enamel?
Mm-hmm. So enamel consists of 96% inorganic substance. So there's a lot of hydroxyapatite that we can bond to, and it's a very dry surface. So whenever we can, especially young patients, we do want to preserve as much of their tooth structure as possible for the longevity of their teeth. But however, there are still some dentists that believe by removing a lot of tooth structure, by providing the strongest material, that the tooth can last for a long time. It was certainly the case on the right. E.max crowns were done 3 years ago, but unfortunately they fractured. The prep were 2 millimeters subgingival, so you just can't bond to it, and the teeth were also endodontically treated. So in order to retreat, the tooth must be built up first, but also bonding is no longer ideal in this kind of cases. That I'll be looking at some material to lute in, stronger material like PFC, and then we just luting rather than bonding. And a lot of cases we do, of course, is a combination of enamel and dentin, which we'll cover at a later stage. So the other important issue is there's a bonding versus cementation. So yes, when there's enamel, we can bond very well. It is certainly the case on the left. Patient in the early 20s had a congenital missing lateral incisors, and who had a canine build-up, who wants to have a better smile and to porcelain veneer in the middle. But the case on the right, it was a failing overseas dentistry with E.max crowns, where I've decided to do a PF crowns, but luting rather than bonding. So bonding to enamel, we have the purpose of the etch is to expose all the crystal rods that we can bond to. So what we are looking for is, after etching, we want to have that that white, frosty white appearance. If you don't have that frosty white appearance, then basically it's better to etch for a little bit longer. So rather than 15 seconds, you can go for 30 seconds, or get a sandblaster just to clean the surface and then etch again. So the etching time, the ideal is 15 seconds, but when you're working on multiple teeth, sometimes could be challenging. So I always start with one. And then, but I come back to the first one and then rinse, just to try to keep within that 15 seconds, and then try not to do over 2 or 3 teeth at a time. But what you don't want to is over etching of more than 30 seconds will result in reduction of the mineral contents, and also reduce the bonding strength. So the gold standard is the total etch for the enamel. So there are some manufacturers that recommend you can self-etch the enamel as well. So the self-etching, they are mild acidic to high acidic. The current ones that work well are mild acidic, because the high acidic one will result in a degradation of the bonding over time. But regardless of the mild or high acidity, the bonding strength is significantly reduced compared to total etch. So always etch the enamel. Don't rely on the self-etch. So enamel bonding protocol, in this case, I mean, the patient had external teeth whitening. So the challenge for this case, the canine does not whiten so well. So after the initial 2 weeks of take-home teeth whitening, the patient had another 4 weeks just on the canines to whiten them to the same, almost to the same shade as the neighboring teeth. However, should the canines be more darker, then significant reduction does have to be involved. So they say it's about 0.2 millimeter reduction per shade change. For a patient with unpredictable oral hygiene, I'll prescribe a chlorhexidine mouthwash twice daily, just to get the gingival health good. Then of course they go back to the referral dentist for scale and clean. So to make sure we have a very good bonding surface, micro etching with sandblaster is good, especially when there are some external stains. But it's very important to floss in the interproximal area or palmars to clean at least. Etching is with 35% phosphoric acid, and 15 seconds is ideal. So when I work on 6 teeth, I like to do the 2 centrals first to make sure the midline is good, and also takes the pressure off, rather than cementing the 6 at a time and then just working on the right or left as your preference. Yeah. Then applying the bonding agent will be in the enamel only. We don't need the primer. Yeah.
Terrific. Thank you so much. Tough case, but a beautiful result. In terms of the flexural strength of feldspathic porcelain, we're looking at somewhere between that sort of 70 megapascals, which is very, very similar to tooth enamel. So I guess one of the take-home message of this particular graph is that these restorations, they're not that strong. And that's why you need to bond that to a very good substrate, much like how tiles work. If you put a piece of tile on sand, then you stomp on the piece of tile, well, your tile's going to crack. But the same piece of tile, if you were to bond that properly to a concrete substrate, then of course all of a sudden that tile seems to be stronger. It's still the same piece of tile. So that's how essentially these ceramic restorations work. They're not really indicated for endodontic treated teeth. Now, in these finite element analysis studies, you can see that the anterior incisors, often the loading is not axial. So through non-axial loading, most of the stress is concentrated on that buccal cervical region. And if that tooth is endodontically treated, of course, that tooth could exhibit even more bending moments. So that could mechanically debond the restoration, or increases the loss of that bond at the cervical region, and thus increasing micro leakage. Another reason is that with endodontic treated teeth, there's always the potential for discoloration. So sometimes if that tooth becomes discolored and we know that these restorations are very thin and they don't really hide discoloration well, and so therefore that discoloration could come through. As Agnes was saying earlier, that feldspathic porcelain could be used as an individual material to construct feldspathic porcelain veneers, or to be used as a layering material over, say, PFMs that we all have used before, or porcelain fused to zirconia, or even lithium disilicate. So, and there are some clinicians that is certainly transitioning away from PFM. That perhaps it's a pressure from the patient saying that I don't like metallic restorations in my mouth. Other times is maybe by ceramists that's saying that all ceramic restorations perhaps are prettier than PFMs. So there seems to be an industry shift away from PFM a little bit. And so could you tell us a little bit more about that? How is this PFM perhaps made using feldspathic porcelain? And what are the clinical indications for this restoration?
Okay, thanks, Ben. Well, with PFM, a lot of clinicians have moved away, trying to move away because of the aesthetic challenges. But we have to remember PFM have a 50 plus years of good clinical outcome. So it's such a long track record we can't really deny. So with PFM, you've got the feldspathic porcelain, which is a weaker material. It's got the 60 to 70 megapascals in terms of strength. But the advantage there, we've got the underneath metal core and foundation for this restoration, which makes these a very strong material. So in terms of clinical steps, we have to always come back into our diagnostic wax-up. So when we send our ceramist a model, we need to remember that the ceramist will need a specific dimensions and measurements to be able to give us an aesthetic PFM crown. So building up onto that, we should make some reduction indices. These reduction indices will dictate how much tooth reduction we provide, and then moving from there, when we give that to the ceramist, they will use the same indices to actually build back the shape of the crown, and hopefully we have given them enough space to give us a aesthetic PFM crown. So the first stage, we all sort of probably studied that at school. They do a wax up for the metallic core. So when they do like the core, it's a metal core. It's approximately, they do require about 0.3 to 0.4 millimeters on the labial aspect. So this then is covered by an opaque layer, which is again 0.1 to 0.2 millimeters. And then they start to layer the dentine layer and then the enamel layer. So overall, we do need approximately 1.5 millimeters on the labial aspects, and not to forget, we still need 1.5 to 2 millimeters on the incisal aspect to be able to, for the ceramist to be able to produce a nice looking crown. There's a lot of advantages for PFM crown. One of them is, even though the crown may fracture, the ceramic layer may fracture, you still have the underneath layer that still seals that tooth structure nicely. And it has, because of the metal substructure, we are able to mask any discoloration of the core underneath. So for example, in this case here, you can see that the subsequent recession, that dark discoloration is evident. And with the PFM crowns, we can nicely and safely extend these margins subgingivally. We can design the margins to be only in metal or gold, so it has a nice hue through the gingival tissues, and mask this discoloration, whether it's a discolored endodontically treated tooth or a metallic core that we have done. Also for this case, where we have a deep subgingival mesial and distal caries in the lower molars, we're really unable to sort of bond anything in that position in the mouth successfully. So we rely on a restoration that with long bevel margins. So you got to extend the gingival, subgingival, almost to the crestal level, as you can see here on the crowns. so almost to this crystal level, and we can achieve a predictable seal of this restorations. And sometimes also with bruxes, we can really extend the gold, finish the gold on the occlusal or finish the gold on the incisal edge to provide a more protection for the restorations than the track. Short clinical crowns as well. We can create grooves, receipts, so which we can't really achieve with all ceramic restorations. With dentures, they're great for partially dentate patients because you can design guide planes, single armrests, which will help in the seating of the dentures. So provide not just added retention, but also support and stability for the denture. Thank you, Ben.
Phew, so that means we don't have to rely on all ceramic restorations. No. There's still some indications for that.
Absolutely.
Thank goodness. Thank you, Zoe. Speaking about PFM restorations, we all know that by the time that you have carried out sufficient reduction, like Zoe was saying, 1.5 millimeters on the facial and up to 2 millimeters in the incisal aspect, you're pretty much down to dentine. Sure, you may still have a color of enamel, but primarily that tooth is onto dentine. So let's talk a little bit about dentine bonding, because a lot of the clinical cases that we treat, yes, while it's always important to rely on enamel, but sometimes you're only given dentine. So Agnes, could you go through with us, what is dentine bonding all about, and can we predictably bond to dentine?
Certainly. So there are many clinical situations where we have to involve dentine bonding, whether it is part of sealing this dentin in the process, or whether it is in part offering some retention and resistance form to your restoration. It is a very important concept to not only understand, but to be able to understand it enough so we can apply it to how we design our restoration and how much can we rely upon it. And this is one of the typical questions that we get asked a lot is how do we decide when it could be just a partial coverage or full coverage, etc. And when can we bond or lute? So let's have a look at dentine bonding. With ceramic restoration, they are fantastic on taking compressive stresses, but they're absolutely appalling in handling any form of flexure. And certainly then that puts the challenges onto this bonding interface. So it does matter what the matter is underneath. When we look at dentine bonding, it is quite different to what Johnson had already presented with enamel, in that what is critical is this formation of a hybrid layer. The dentine is primarily an organic material, so it involves 3 chemical processes to form this hybrid layer. Now, as I take you through it, many of you may think that it sounds very familiar to how dentine bonding first emerged, and it is this 3-step system. And along the way became 2 different varieties of 2, and then just 1 step. Now, forget about the steps for now, but whether it is 3 steps, 2 steps, 1 step, this chemical process still needs to occur. So the idea is to first etch and get rid of some of the mineral content. So we're still talking about getting rid of some of those hydroxyapatite, that is peritubular, intertubular, removing that smear layer, and then putting a primer in that hangs the 2 together. That's the middle layer that grabs hold of the tag ends as well as form a bond with the resin. But what exactly do these mean clinically and to our patient, how they respond to the dentine bonding process? So here gives you a better picture of those different steps. But in the end of the day, all 3 chemical processes still present. So the very first step is the etch. This electron micrograph gives you a very, very good idea. After we prepare a tooth, whether it's just a cavity prep or crown prep, there is the formation of all that debris that collected and formed this smear layer that we know of. And this, whatever the smear layer that gets into the dentine tubule is what we call the smear plate. First of all, in the etching process is we want to get rid of this particular layer, and we do so by etching the dentine for that 10 seconds in traditional technique. It requires only 10 seconds because you don't want to over etch this surface, and you must then wash out this acid really well to have no residual acid left. If you etch too much, then these dentine tubules will be too far open. And if subsequently the primer and the bond does not infiltrate it enough to what you have opened up, there could be postoperative sensitivity. Now, as we have finished washing out this acid, we then have to dry it before we apply the primer. And it is this drying process that is even more technique sensitive. When you over dry the dentine, so essentially what happens is the dentine surface, it's like up here and it's all pretty even after the preparation. And after the initial etching process, we have up to about 0.5 of a micron. It's not much. It's anywhere between 0.2 to 0.7, however well you clinically can etch in that one step. And what we want now is to keep these fibrils, these collagen fibrils, standing up tall to grab onto those primers. So that is why people always talk about you need wet dentine, because as soon as you blow air on it, they collapse. And once they collapse, there's nothing really much to grab onto. But what's more is you can't really re-etch this. You've already etched it, and now the collapsed fibrils is just sort of in the way for the primer to infiltrate anywhere. So if you ever happen to think that you've over-dried this dentine, especially, like Johnson have described, you meant to etch the enamel first, so you do that. You do that for the first 5 seconds, and then you total etch now onto the dentine. And then as you wash this etch off, you're very eager to see that chalky enamel, so you then go and blow on it. And not only do you see the chalky enamel, now you see that matte dentine look. You've over-dried the dentine. The dentine should always stay moist and glisten with the shine. No puddling, we don't want moisture contamination, but it should have a shine. If you see that matte dentine, it's very important you recognize this. And the way to fluff up those collagen again is by a wet cotton pellet. So not too wet, just the wet cotton pellet, and you leave it on the dentine for a good 30 seconds. After which, you remove that cotton pellet. Do not blow dry anymore. Trust that you've got that chalkiness on the white, on your enamel, and that you've now moistened back up the dentine. And I'll take you through the next phase, which is the primer. So with the priming, what it does is now that you've got those standing up tall collagen fibrils and you've etched into some other peritubular areas and opened up some dentine tubules, you want to rub this primer and get it infiltrate as much as you can so that it will have a relatively hydrophilic end to grab into this organic structure into the dentine, but it also has the hydrophobic end to bond with the bond. And the reason why you need to rub those 20 seconds is that you want to infiltrate this depth, as well as to get rid of the solvent that is also in this tub. Once you're able to do that, then the primer, the bonding agent now can go on top, having good moisture control, no contamination, and you can now have that bond or the resin cement. So as you can see, it's very, very technique sensitive. Mm. When everything works well, it will work well in some hands, but it's not always predictable in the operator or clinically in every case. And that is why there is this surge on having the 2-step and the 1-step. Not only is it meant to create clinical efficiency to save us time, but you have a more routinely predictable outcome to achieve a good dentine bonding. And essentially, as you look at the slide, instead of looking at groups such as whatever generation, I like to understand it in terms of just selective etch or total etch, or people will call etch and rinse, where that strong acid is in a separate bottle, that you can use it well and rinse it off. Or on the other hand side, you have the self-etch, which you don't have a strong acid to deal with, but it is an acid that you have in the bottle that you dispense with, and also that you leave on the tooth that you apply on. And now I think at this stage, the audience now know why it has to be only a mild acid, because the mild acid works well for dentine. And that is why there's this efficacy, even though whatever they may disclaim, it is important as we use those self-etch bottles to still etch the enamel and only the enamel separately. And this acid, as I will take you through, will also impact on your bottle's shelf life and stability. On the left-hand side in this electron micrograph, you can see what happens if you etch separately. You can form deeper into this tag and deeper into dentine tubules, but it's all very variable in how much you can then infiltrate the primer and the bond into this area. Whereas in the self-etch system, because the chemical process is being undertaken by its own, however far it can infiltrate will be however far it would create these tag ends and successfully form a primer and a bond, even though it may not achieve an infiltration as deep as it seems in the total etch system. But the final result is still a very good initial dentine bonding because of this uniformity of the hybrid layer that is first described by Nabakayashi. Because it is not only the depth of this hybrid layer that provides the dentine bond strength, is that uniformity across that whole section. So now that we have that background understanding and what it implies to us clinically, we can now see that as we move along to the different generations, why they have existed, and why because of the acidity that is in the one bottle system, that acid is what can affect that shelf life. And ideally, when you dispense this product, it should not be pre-dispensed, but rather it should be dispensed just as you're about to use it, so that it will be more stable. And in the universal category, the different manufacturers have now on looking into adding other things like MDP to increase the stability of the bonding that can be achieved, as well as how it holds its shelf life within the bottle as well. And of course, just to let the audience know, but I mean, technically, it doesn't really change what my final summary recommendation is, that there are generations that have nanofillers that help that depth of infiltration into the dentine tubules more, as well as Vitroma to be a little bit more tolerant of that wetness in the dentine, keeping the collagen fibrils up. So the take-home summary is that I think where possible, using the self-etching product where the chemistry does work in itself can be a bit more universally predictable in the outcome. But you do have to rub it on for at least 20 seconds over that dentine area to ensure that infiltration of the product to do its etch, prime, and bond, and to allow it to evaporate. To dispense the product only prior to use, and watch out for the expiry date, and always be working on this moist dentine. And for those audience out there who are still using an etch and rinse system, there's no problem with that if you find that that has worked very well in your hands and in all your cases. But a sensitive tip is just to ensure you do not over etch and you do not over dry. And again, always have that moist dentine prior to the priming and the bonding. Thanks, Ben.
Well, excellent summary, Agnes. There's one question from the audience that asks, what's the preferred cement? Of course, I know you're talking about resin bonding, but sometimes if we talk about a PFM restoration, may not necessarily needs to be resin bonded to dentine because you may have sufficient retention and resistance form and full effect, etc. So you may want to lute or just simply cement this restoration. Any particular cements that you would recommend?
Okay, so when I'm not doing dentine bonding and going through a more traditional method of luting, and of course there would be already mechanical features having thought that process through, then I would use a resin modified GIC to quite happily use that as a form of luting agent.
Right, thank you. And that, and just to the audience, you mentioned earlier some resin bonding systems, they contain nanoparticles, or nanofillers. Depending on which literature review that you read, some of them suggest that that should be called an 8th generation bonding systems, while others literature seem to have completely skipped this 8th generation and go straight to universal adhesives. So it certainly can make understanding confusing. And
that's why I think it's much easier to interpret, like, you know, even with the different 2 steps, because 2 steps alone could be etch and rinse with prime and bond, or the etcher and primer and bond, which is actually a self-etch. The most critical part, it really, in understanding all of this in terms of clinical application, is just to see whether that product is an etch and rinse or it's self-etch. Because one, you be more technique sensitive, but if done well, and controlling the post-op sensitivity aspect, the infiltrating of the primer, and provided, of course, you wash the acid thoroughly through, then you don't have the concerns of any residual acid. And certainly the primer and bond bottle will not have this strong acid that, or even mild acid that is in that bottle. Whereas in self-etch system, it's important to recognize that, that there is that mild acid that is in that bottle, which will affect its shelf life, as well as how it works, and in that interface. But provided that it's a mild acid that, trusting that the chemical reaction takes care of itself, it can more reliably give you a uniform dentin thickness. Again, the only technique sensitive issue here is spending a good 20 seconds of really rubbing it in, because you still need to infiltrate and trigger that infiltration, not just apply and blow.
That's a very good, important take-home message. Yeah. So with the universal adhesives that Agnes previously covered, what is quite confusing about that, I thought, is that there are some systems that in the branding, it has the name so-and-so, such and such universal or universal bonding agent, but it doesn't actually meet the criteria of the latest generation in universal adhesive. And by universal adhesive, there's no equivocal definition out there. However, in concept, it's a resin, bonding resin that supposed to work for either with total, selective, or self-etch. It's supposed to be good for compatible with light cured or dual cured resin cement, and you're supposed to be able to bond to everything and anything under the sun: enamel, dentine, metal, ceramics, whether etchable or not. So that's in essence what a universal adhesive is for. Now, whether it contains nanoparticles or not, it doesn't really matter, but the application is universal, and that's what universal adhesives, that's what they should be called such. So just because a bottle says is universal doesn't necessarily mean that it meets all those criteria, and that's what makes it quite confusing. So sometimes you unfortunately do have to read that product disclaimer a little bit more carefully before you will just go and use it universally. But I understand that as a practice, it sometimes makes good sense to have these bottles there, because there's all these different clinical things that we're going to do every day, whether it's to enamel, to dentine, using a variety of different things. And if you have 3 or 4 different type of bottles there, it's hard to keep track of things, of the expiry dates. The nurses have to prepare the right things. And if you do put these things in the fridge, you're supposed to take them out half an hour prior before using, because you're supposed to use it in room temperature, not just out of the fridge. So there's all sorts of issues. But yeah, and then the other thing to note, of course, not all self-etch resin bonding are the same. You got your 6th, your 7th, your 8th, and now your universal generation. They certainly do have different bond strengths. So that's another something to look into. It is a broad topic. So if there's any specific questions, then please do feel free to ask the panel. All right, so here's a question for us. Can you etch and rinse the enamel and then use a universal bond for both dentine and enamel bonding? I guess the answer is yes.
Yes.
Definitely. So what we're saying, and just to repeat, in case the audience has missed that take-home message, we're quite an advocate on selective etch. So we believe that you should be using a separate etch protocol for your enamel, and then using a self-etch primer of some sort to etch and to wet your dentine to bond to. So let's move on to the next category of ceramics, which is still there's a lot of glass, but now it's increasing in that crystal filler content. Starting from your first generation in this subcategory, leucite reinforced. We all, I'm sure, heard of Empress. It is a material that was released by Ivoclar Viviclean, which has roughly about 50% of leucite crystals, compared to your feldspathic porcelain. It could be somewhere, say, 25% on average. And because of the increase in crystals, therefore, if you have a crack, now you have to navigate and travel through more particles before you reach the other end, and hence increasing the flexural strength of this material to roughly about that 150, somewhere around there. These materials are reasonably translucent, so therefore you can make good aesthetic restorations. Could be veneers, could be anterior crowns. However, I probably would not recommend using this material to construct a posterior molar crown. Now, this image is grabbed straight off the manufacturer's website. Now, because of the success of that material, but still the limitation because of the mechanical properties, so quite quickly they've released the second generation, which is called Empress 2. But it's a slightly different crystal now. It's now lithium disilicate. So lithium disilicate is a very unique crystal that it forms these interlocking plate-like structures. And on top of that, the crystals are grown in random orientations or directions, which means that if you have a micro crack, you now have to traverse through this very complicated 3D matrix in able to reach the other side. So that's why mechanically it has significantly improved when compared to Empress 1. However, the veneering porcelain onto this material, for example, feldspathic porcelain, veneer porcelain onto this has some early days debonding issues or shearing issues. And that's why Empress 2 sort of came and went on the market reasonably quickly. And that's when they released E.max. So it's a new branding, supposedly for a new material. I think it should be called Empress 3, but based on the chemical composition, because it's still lithium disilicate. But now they've tweaked the chemistry, the way that they make it, things are a lot more robust, and they've now overcome that initial problem that they had. So it's still lithium disilicate crystals, like the second generation, but mechanically it is working better. So flexural strength-wise, you're looking at somewhere around that 300 plus to up to about 400. These materials are terrific for your inlays and onlays for these restorations with secondary caries. You remove it, as Johnson was previously saying, that you do want to preserve as much structure as possible, leaving as much enamel as you can. Construct the restorations. This is just with staining and glazing. We've covered previously how to etch these etchable ceramics, and we've covered how to prime and bond to dentine. And any clinician can make restorations like this. We've also covered that it's very important to etch these etchable ceramics using a separate hydrofluoric acid etch step, because yes, there are self-etch materials out there which you can etch these ceramics. However, you only get a weak, because of the weak acid it has, so therefore the amount of penetration or the removal of the glass, it's not as much as using a 5% hydrofluoric acid etch separate step. I'll take this clinical case here, for example. This is a patient with a discolored central incisor, tooth number 21. There has been a composite veneer that's been placed. However, as the tooth continues to discolor over time and the breakdown of the material, the patient wanted something that's a little bit more durable, a little bit more long-term, rather than just leaving it as a composite veneer. Unfortunately, we don't have the luxury to whiten this tooth internally using non-vital bleaching, because the tooth is vital. So after we've gone through all the different options, the patient opted for a porcelain veneer. And here you can see that once we've reduced that tooth structure, there's a lot of dentine that's now exposed. Now, some of the viewers at home may feel that, well, that's a very aggressive prep. I would have never done that. But for a etchable ceramic, you've got to give your ceramist enough room for that to work. Otherwise, I think you should probably use something like a PFM. So that's the amount of reduction that we have to do, which is about 1.4 millimeters. And then even then, you can see that these restorations are very difficult to completely hide that moderately discolored tooth. Now, Johnson, you work a lot with aesthetic restorations, a lot of all ceramic restorations as well. Could you go through with us, what is the thought process behind how much tooth structure do you need to remove in able to achieve that result?
Yeah, great. Thank you very much, Ben. So it all depends on how much the discoloration is. So ivoclavicular dent have what they call the natural dye material. It's a composite resin dye material developed for the technicians. So rather than pouring the dye in the stone, so they have these resin dyes that they can use. And once they make the ceramic crown, they can check on the resin dye to ensure they have masked all the discoloration before sending to you. So what you don't want is to receive a crown that doesn't mask the discoloration, and that can become a surprise for both you and the patient. So the way they categorize is the natural dye material 1 to 3 is what they consider mild discoloration. 4 to 6 is moderate, and then severe. Basically, any brown discoloration will be moderate. Any gray discoloration will be very difficult for the technician that will be in the severely discolored. So if you look at the masking ability, if you look at this, I mean, PFM is the ultimate in blocking or masking all the discoloration. But unfortunately, even with 1.5 millimeter preparation depth, we still see the opacity, the stain coming through. So hence, I mean, my technician tell me if you give me a 1.8 or 1 millimeter prep, basically a compromise the tooth, we can give you any result with regard of the material they can use. But if you look at this, I mean, the most conservative would be the E.max loss translucency. So, but of course, it doesn't block out any moderate or dark discoloration. The best all ceramic masking will be E.max high opacity. My technician described that as a toilet bowl white. They need about 2 millimeter prep in order to give you a natural result because it's too white. Mm-hmm. So this is 0.4 millimeter coping. So if they use 0.6 millimeter coping, that means they need more to mask. Mm-hmm. And hence, very commonly, they use 0.4 millimeter coping. Zirconia does mask better than E.max medium opacity, but it requires more tooth preparation. Hence, a lot of technicians still prefer for moderate or heavy discoloration to go to the E.max medium opacity, because they can get a balance between the masking effect and also live looking crown. So if we look at the masking ability of the 0.4mm E.max low translucency coping, it will be only able to mask mild discoloration, and the minimum preparation depth is 1mm. So in the case Ben has discussed previously, if the tooth is endodontically treated, definitely do want to go down the pathway of non-vital tooth bleaching rather than putting a veneer on this tooth, especially it's a pure dentine. That would not be good. So this could be only for vital tooth as a veneer option. But of course, to warn the patient that there's going to be more frequent debonding when it's bonded onto more dentine. But in a young patient, sometimes no choice is more important to prolong the longevity of the tooth rather than giving them something that will last longer. In terms of 0.4mm E.max medium opacity coping, it will mask moderately discolored teeth. So in the 4 and 5, in the 6, you will not mask completely. So what the technician does is they do a white stain technique, which I'll describe later in the combination to reduce your, so you basically don't have to prepare more, but the absolute minimum for a very talented technician is 1.4mm. I've done a few of the ceramic courses to learn how to communicate with them. I mean, if I was a technician, I would need 1.8. So I've got a case, patient had an E.max crowns done 2 years ago. And I asked the patient, was it gray from day one or was it progressively? So the patient was saying, no, it was discolored from day one. And the perception from his family and friends was saying, oh, you don't seem to know how to brush your teeth well. So he came to me, he just wants these crowns replaced so we can look normal. So it's a high aesthetic driven case. So the options were PFZ because it's majority denting or longevity, but of course require more tooth preparation. He's a high aesthetic driven case because he only had these crowns for 2 years. Upon discussion with my ceramist, we decided to go with the E.max crowns. With all ceramic crown is very different. So you need to look at the color of the teeth prior, and then you need to take color of the core as well. So my technician has taught me that always pick the darkest core shade that is. So this is the Ivoclar natural dye, the shade guide. Basically, you pick out any of the shade guide and then take a photo upon removal of the crown before the teeth dehydrate. If after refinement and then after picking the retraction cord, the teeth will not appear very discolored, and they can give them a very false perception when they choose the ingot for the E.max crowns. The alternative is to use any other shade guide as long as they match the color of the core. So my technician has decided to use E.max medium opacity coping, and this requires 0.4mm of space. This will not mask a severe discoloration. So what he does is he put another layer of white stain that takes another 0.1 to 0.2mm. And then he put deep opaque stain or some deep dentine fired. So currently we require 3 different methods of masking that. And the other layers were just to make it live looking. My technician liked to still put the wax just ensure all the layers is all the same, because porcelain shrink up about 25%. So it's really relying on their experience to know how much to put. And then they fire again. And then now we only have about 0.2mm for the final enamel. So 1.4mm seems to be a lot of space, but when the technician or when a very talented technician work on it, it's actually not a lot of space at all.
Not a lot of room for error.
Not a lot of room for error.
And often they have to do multiple refires.
And
changing the shades. So I do not envy that job.
No.
It's a very challenging case, but otherwise an excellent outcome. And what was the cement that was used here, Johnson? Would you recommend using a dual cure resin cement?
Yeah. I mean, even though this is an opacious gold, so definitely need to have the dual cure resin cement. The traditional resin cement have a tertiary amines in it. So, but the newer cement they're called aesthetic cement, although they do not disclose what they have replaced with, but those tends to be more color stable, the aesthetic dual cure resin cement.
Sure, that's great. Another question that the audience has asked is, we were talking about universal bonds before. Any particular brands that falls under that particular category?
Oh, I think majority of the brand have all their universal, whether it's Kerr adhesive or
Optibond Universal, that is?
Optibond Universal, Universal or Carrare, they all make their own universal. Most of them contain 10 MDP, some of them contain silane. But the thing is, I still believe having a separate primer for the ceramic achieve a better bonding strength in the long term.
For sure, And we'll certainly talk more about MDPs and primers in just a moment. That's coming up. So let's move on to the third group, and we don't have to spend a lot of time on this group, which is primarily crystals and with some glass infiltrate, because not many technicians do use this material. There's a few brands out there, but the most prominent one is it's called Vita, called In-Ceram. There's 3 different subclasses. I think it's spinel, alumina, and zirconia. So particularly the core. For example, if we are using the alumina core version, the framework is actually constructed using a slip cast technique. So it's essentially lots of crystals. In this particular picture here, you see that the alumina, it look like these big rocks-like things, look like in a riverbed, which is actually the glass. So there's not much glass, but primarily in these crystals. The problem with this material is because of whether it's human errors or operator errors, during the infiltration stage of the glass sucking up back into the frame, the alumina frame, by capillary actions, it's not very even. So sometimes you end up with porosities inside, and that's what's caused some of the reduction in the properties of the ceramic. Another issue is the manufacturing stage, which just constructing the framework alone needs 2 separate firing sessions, one 2 hours, the other one about 5 hours. So that's one of the key reasons why a lot of ceramists don't like to use it, because of the significant amount of time that's involved. But I've seen some very good aesthetic outcomes using this material. So depending on which is the type that we're looking at, whether again it's the spinel, whether it's the alumina, whether it's the zirconia frame, that you can have a good mix between higher aesthetics, translucency versus a higher strength outcome. So moving on to the 4th category, the poly-crystalline structural group, which we're now talking about alumina or zirconia primarily. With alumina, that was first released by Noble Biocare called Procera. It's still around, which is a 99.9% alumina in terms of a coping or a framework, and then it's subsequently layered with feldspathic porcelain. But then it's later on somewhat superseded by zirconia because of its improved mechanical strength. So here in these graphs, you can see how much more potentially so-called stronger zirconia is when compared to alumina. Most of these polycrystalline structures or restorations are made by CAD/CAM, meaning that you first have to scan either intraorally or a model, scan these into a computer software, and then you're going to design it, the right restoration. Then it is milled out of a block of pre-sintered material, which is about 25% bigger. Then after the firing process, that material shrinks down exactly the right size, which is quite incredible. And then subsequently, that material is either just stained and glazed into a monolithic material, or it could be either cut back or previously designed to to allow for a feldspathic porcelain layer to be added on top to turn into your final restoration. Zoe, could you tell us a little bit more about zirconia? Why is this, it seems to be the go-to material in a lot of the clinical situations? What is magical about it?
Sure. Well, I think you mentioned, Ben, with alumina, it was superseded by zirconia. And the reason for that was this material came out and it has a lot of better mechanical properties, it's a higher strength, but also 20% less thermal conductivity as well.
Right.
So zirconia, basically it's a metal oxide. It's an interesting material. It does go through a phase, a transformation. So it's transformed from one crystalline state to another throughout that firing stage. So initially at room temperature, it's monoclinic, and then as you fire to 1,200 degrees Celsius, it becomes tetragonal, and at 2,370 degrees, it becomes cubic. The cell volume also changes, so it is larger, about 4.4% when it is a monoclinic than when it's tetragonal. Now, throughout that firing stage, actually, there's a lot of change in the cells as the materials start to cool down from really high temperatures to room temperature again. There's a lot of stresses that causes cracks to initiate. So that crack propagation through the material as it transforms from cubic to tetragonal back to monoclinic is a problem. But as the material expands in cell volume, it actually, in the monoclinic phase, it actually compresses that crack. And it helps retard its growth and also enhances the fracture toughening. So that's why it's called transformation toughening. Now, the mechanical properties you mentioned, you showed in the graph earlier, it has a flexural strength of 900 to 1,100 megapascals. High compressive strength, fracture toughness is 8 to 10 megapascals, high fracture resistance. It is one of those materials that we can actually veneer with to achieve a better aesthetic results, but then we have to reduce more to structure. Or in cases where we have a limited reduction or not so high aesthetic areas, we can really go for something that's monolithic zirconia. It's got a lot of advantages in terms of the strength, but also it's quite kind to opposing enamel. As you know, veneering porcelain, it has one of the highest abrasiveness against opposing enamel, followed by glazing of the zirconia, and then the highly polished zirconia seem to have the least kind, or the most kind to tooth enamel. There's some difficulties in adjusting occlusion, and I do recommend that we do try in the zirconia crown early on in the mouth before cementation, do the occlusal adjustment, and then use certain protocol. There's some Eve products that we can recommend for polishing the zirconia to achieve that highly polished surface before cementing it in the mouth. It just makes life a lot easier that way.
For sure. Johnson, I believe you have a case here which has really utilized some of those mechanical properties of zirconia. Could you describe for us what this case is about and why did you choose zirconia in this particular case?
Yeah, so thank you very much, Ben. So this is a severe class 3 case with a narrow maxilla. He's complaining of an aesthetic partial denture replacing the maxillary incisors, but also unretentive partial denture. Due to his severe narrow maxilla, the premolars where the clips are retained onto are basically tilting in lingually. So that will never provide adequate retention for the any partial denture. So we discussed various options, including orthodontic surgery to correct his class 3 malocclusion and implants, which he rejected. So not many people are keen to have their jaw split in half in advance. So
I recall that he also had a functional issue too. He had a lot of difficulties with chewing. That's why he wanted to have those teeth restored. His occlusion improved to increase the contact, wasn't it?
Correct. So he had various dentures. Some of them was where the upper incisors or retroclined,
Yes.
or so basically, it just can't chew properly. So we discussed various options, and we agree with increasing his OVD, but regardless of how much I'm going to increase, the cast tips will still be in crossbite.
Yes.
So my concern with using PFM or any layer material would be chipping off the porcelain very easily. And so I've decided to use a monolithic zirconia in this case. Oh, sorry. I'll click the right way. All right. So this case was done 10 years ago. At the time, only the high opaque zirconia was available at the time with some external staining. So it's very important to communicate that he does have expectation for the teeth to look better in terms of the form, but in terms of the character of the teeth, he is not after a high translucent case, as any monolithic material without layering will not look very good in terms of character of the teeth. It does look reasonable, so hence we went ahead and then fitted the zirconia crowns first. It's very important to ensure the bite is correctly to have ensure minimal adjustment. So the coarsest burr you can use is what they recommend is a yellow bent diamond, which is very minimal adjustment. You basically just remove all microns at a time, and then you use the zirconia polishes. You need to be very specific because they have it for different types of porcelain, feldspathic or E.max.
Johnson, could you elaborate a little bit more on polishing, because that's a common question that's popping up. What is your protocol when it comes to polish different types of ceramics? Because, for example, I know that Kerr actually have these polishing kits available for different type of ceramics.
Yes. So they do need to be specific to the type.
Yes.
Zirconia is zirconia polishes. E.max is E.max polishes, and then feldspathic is feldspathic polishes.
Yes.
So you do accumulate a number of these kits.
We do have a number of them in the practice.
Yes. But the best way is to ensure the occlusion is correct.
Yes.
Should significant adjustment required, one would be crack propagation. So always send it back to the ceramist to heal the cracks per se. But
as a general rule of thumb, do you have a protocol in mind adjusting ceramics? So, for example, some clinicians adjust them without water because they felt that if you use too much water, it's hard to see the blue contact paper markings.
I see.
So often they may turn the water off.
I see.
Is that something that you would recommend, or that's what we're trying to ask?
Oh, I see. Yeah. Definitely need to adjust with copious water, regardless of the ceramic type. And like Zoe was saying, it's definitely much easier to, during the trying stage, to ensure everything occlusion is perfect. So with water, I either hold the cup and the crown, adjust chair side, or I just get the handpiece to the sink and then adjust that way. So I can have copious water without worrying flooding the tray or the cup or on the floor.
Or the patient's mouth for that.
Yes.
And I think if intraorally you find that your ceramic is difficult to pick up the articulating blue as you are adjusting the occlusion, one of the way is just to dry the surface of the crown, and then you can apply a little bit of Vaseline onto the paper, and in that way it marks a little bit more easier for you.
Great.
Great. And then we provided him with a denture by designing the undercut into the crowns, and I've used a gold rod wire, which is provide a little bit more passive fit for the crown. And what I've utilized is a rotational path of insertion. Often the denture you receive back, they remove the undercuts, acrylic pink undercuts in the mesial of the threads. But for the rotational path of insertion, you definitely do want to get your technician to lock into those undercuts. But unfortunately, it's a lost art. Not many technicians do it.
Sure.
Still a compromise result, but nevertheless, an improvement.
Absolutely.
That's
I'm sure I recall the patient was very happy with the final outcome.
Mm.
Unfortunately for this case, we couldn't do one of the ones that Zoe showed earlier, which was PFM with milled guide planes
Yes, yes.
and red seats, because that could eliminate those clasps.
Yes.
But if we did PFMs in this case, I think we'll come back with a very unhappy patient with chipping of the feldspathic, the porcelain casters pretty soon.
Yeah.
Now, zirconia is not all the same, because just like any other ceramic material, it certainly also has different generations, and different companies are making all sorts of variations of zirconia. Today, zirconia is no longer the monolithic, very opacious, white-looking ceramics anymore. They come in a variety of different colors, and also a variety of different translucency. Some of them are, in fact, quite translucent, that it's very comparable to your lithium disilicate or your E.max restorations. Now, one thing to note that whenever, as a general rule of thumb, if your zirconia is becoming more translucent, and so is the reduction of the flexural strength. So much so that, for example, in your ultra-translucent katana zirconia range, according to the manufacturer, you're looking at about 550 megapascals, which is half of what a traditional zirconia is about. So all of a sudden, you are sacrificing some of those mechanical strength properties for aesthetic properties. So in other words, if you are asking your ceramics for, I would like to have a monolithic zirconia crown for this particular case, because you think that that's going to be the strongest material inside the mouth, and they happen to use a very ultra translucent version because that's just what they currently use, well, you may get a pretty nasty surprise, because that restoration may just fracture. But in some clinical situations, of course, these restorations could be highly aesthetic. So Johnson, could you tell us a little bit more about how you use this material to achieve better aesthetics, particularly in certain cases like this, in the anterior cases, where maybe in that case implant wasn't indicated.
Okay, thank you very much, Ben. I'll recap what you discussed before first. So when sending to the technician, yes, they're using more and more translucent zirconia. It's definitely not indicated for molars. So hence, if you do want to prescribe molars, always say use a high strength opaque zirconia. So basically, they don't use a high aesthetic one for you. So we'll come back to this case. This patient had a failing mandibular central incisor, tooth 3-1. The space mesial-distal width is only 4 millimeters. A bit too small to have a dental implant unless you sacrifice 4-1.
Or I guess orthodontic space opening,
of course,
potentially is another option.
Of course, she basically just want to replace this tooth. So rejected all those other options. So tooth was removed, and then we do discuss all the different options. My treatment plan was to do a conventional cantilever bridge of tooth 3-2. The patient does not want her tooth prepared at all, so that will provide better longevity. And then we discuss various Maryland bridge options. And then she decided to have no preparation Maryland bridge option as well. So for the Maryland bridge to last for a long term, medium to long term of 7 to 10 years, preparation of resin in the cingulum and also grooves on the mesial and distal will ensure we have a very good resistance to ensure the Maryland bridge lasts for a long time.
This is a PFM form of Maryland bridge you're referring to,
No,
is it?
no, also for zirconia as well.
Right,
Yeah,
right.
yeah, of course. Because of the to resist all that twisting movement. So, but her expectation was really really realistic. I asked her, so when she asked me, short term, what do you mean? I said 1 or 2 years. Well, it definitely lasts longer than that. So when I know expectation is low, then I'm comfortable in delivering no preparation Maryland bridge to suit her expectation. When Maryland bridge was introduced, first they are designed with 2 retainer wings, but the research shows that if you have 2 retainer wings, one will debone a lot quicker than the other due to differential mobility of the teeth, especially in perio-compromised teeth. what they also show, in order to bond, the tooth must have no fillings at all. So when you pick which is the better one to do, is pick always the one with a larger bonding surface and no fillings at all. Regarding the material to choose, I mean, I choose zirconia in this case. In earlier days, there were a lot of issues on can we bond to zirconia and what is the bonding strength. And hence, a lot of E.max Merlin bridge were completed. And they were well published in the literature. Some recommend pontic area, connected area 4x3 or 12 millimeters. But the interesting thing is, if you look at Ivoclar Vivadent website, Merlin bridge is contraindicated for E.max. So hence now we know we can bond to zirconia predictably, which Zoe will cover. I'm happy to use zirconia. But what I do with the zirconia, in this case, I sandblast the tooth surface very well, as well as sandblast the zirconia. And I do want to use a separate primer with a 10 MDP for the Merlin to maximize the bonding strength in this case. Yeah.
Would you consider using the PFM in this situation?
Yeah, in mandibular central incisor is a little bit challenging because the metal will show through.
Yes.
Yeah. So, but on a thicker tooth, then yes. Yeah.
Once again, an excellent result for an otherwise extremely challenging case. As this case relies 100% on resin bonding, there's no mechanical retention there. Unlike a PFM Merlin bridge, sometimes we can prep certain grooves in that 45-degree angle to resist some of that forces. With these, there's practically nothing. So you're 100% relying on resin bonding. Zoe, could you tell us a little bit more about how can we more predictably bond to zirconia?
I mean, nice case, Johnson.
Thank you.
The great thing about zirconia, it's really versatile material. So you've used it as Maryland bridges, and it's got good track record on that, and long, like sort of medium span bridges as well, posteriorly in the mat. So how do we bond to it? As we know, successful bonding relies on two factors. First, we need to roughen the surface, so increase the micromechanical interlocking, and then activation of that surface using a primer to form that chemical bond. In conventional silica-based ceramics, we're able to etch with hydrofluoric acid. That applies the saline, and that will act as the coupling between the ceramic and the resin. But with densely sintered poly-crystalline zirconia, we cannot etch with hydrofluoric acid. So what has been recommended in the literature is sandblasting with 50 microns of aluminum oxide. You can see here in this image, electron micrograph, we've got at 1000 magnification a zirconia surface that has not been etched, sandblasted, and a 1000 time magnification of a zirconia surface that has been sandblasted. So what they recommended is to do the sandblasting at 0.1 to 0.25 megapascals pressure, keep it about 1 centimeters away from the surface, and on the fitting surface of the crown, you've got the 5 surfaces, so make sure you spend about 5 to 10 seconds per surface at that distance to ensure that all surface of the zirconia is roughened to achieve that micromechanical interlocking later on. The second stage would be, and with the sandblasting here, we've got, the recommendation is to, once it's sandblasted, then that should be the final step before you're ready to cement it in the mat. So preferably you actually do the sandblasting once we're ready at that cementation stage.
So it's already been tried in
it's already been tried in the mat, cleaned, washed, and then sandblasted, and then you apply the primer afterwards. Because at this study, we can see that if we sandblast and cement or bond the zirconia within 15 minutes, we've got a higher tensile bond strength. And as time lapses to sort of 72 hours, that bond strength tends to decline. So we've got to consider whether we actually allow the lab to sandblast for us, probably is something that we need to to consider that maybe we get a sandblaster in the chair clinically, and we do that ourselves.
The other issue with the saliva contamination is with the saliva, the phosphate in the saliva will compete with our resin cement as well. So if you want to bond to that, you definitely need a sandblaster or Ivoclean to clean the surface so you can bond to it. Yeah.
Absolutely. So I guess what Johnson alluded to is that ultimately what Zoe is going to talk about next is MDP, which contains a phosphate group, which is what is ultimately going to bond to the zirconia surface. But if you have already tried that intraorally, which saliva and other bits and pieces may contain phosphates, and that has already bonded or stuck to the zirconia surface, which means that now you're no longer offering those zirconia surface to the bonding of your primer. So
definitely. Yeah.
So with the primers, a 10 MDP primer has been recommended. These primers, they work they've got the phosphate monomer resin, phosphate monomer component into the primer. And the way they work is they bond chemically to structure, but also have some affinity to the material to the oxide layer in the zirconia. For examples, we've got a dual cure phosphate monomer cements that's present in Panavia F2, Reliax Unisem, and Multilinks. They all have shown a good mechanical retention to zirconia. So I'm not going to attempt to say the name of what MDP stands for, but it was developed first by Carrari in 1981, and since then the patency have expired. So other companies, they started manufacturing resin cements and primers that contain 10 MDP as well. So like I mentioned previously, MDP, it chemically adheres via ionic bonding to the hydroxyapatite crystals in the tooth structure. And that has been shown to be very stable by the low dissolution rate of its calcium salt in water. It also bonds the phosphate monomer in the MDP has an affinity to the oxide in the zirconia, so it tends to bond to that, and it also bonds to titanium. So studies have looked into, it's very difficult when you try to follow what's been reported in the literature on 10 MDP, because there's a lot of protocols. Some do sandblasting for the zirconia, some they contain primers that might have MDP, others contain adhesive, and then the substrate you're bonding to, whether it's dentine, is different, and then whether it's composite. So there's a very different reports in the literature on how these MDP containing primers and adhesives work. But the sort of the conclusion was within a short span, which is a 48-hour, there's a higher microtensile bond strength if you end up using an MDP containing primers and adhesives. Whereas the groups that don't use the MDP containing primers and adhesives, they found that there was a significant decrease in the microtensile bond strength after that 6-month period. So in this study here, we're looking at they assessed different shear bond strengths in megapascals of luting cements. A lot of practitioners, they may rely on glass ionomer cements. For example, in this particular study, they looked at Fuji 1, Kitaxem, Fuji Plus, and Reliax luting cement, which is a resin-modified glass ionomer cement. And if you look into the before thermocycling, the sort of tensile bond strength is quite low on all of these glass ionomer cement. Whereas after tensile thermocycling, that tensile bond strength even drops further. As we know from other studies, the recommended bond is about 10 to 13 megapascals to achieve a reliable clinical bond that's functional in the mat. So a lot of these cements, they haven't really provided that tensile bond strength that we're looking for.
No.
Now, with the exception of Panavia F have shown to have in principle, they have shown to have a higher shear bond strength before and after thermocycling as well. So I believe some of that is probably because they can contain that MDP into the composition of these cements. So, in summary, what do we need to, like a take-home message here? First of all, sandblast. Try in your zirconia surface in the mat. Make sure that you clean it, wash it, and then do the sandblasting. Spend enough time to sandblast the entire surface on the fitting surface of the crown. And then it will be ideal to purchase your own sandblaster in the clinic. Okay, apply the primer immediately, and be generous with your primer application. Make sure that it covers the whole surface, and also that needs to be air dried gently. The primer will sort of evaporate, but make sure that you air dry it, and then apply the resin cement. Use a dual cure resin cement, and if it's an MDP containing, then it will be ideal.
Absolutely. Thank you so much,
Thank
Zoe.
you.
Couple of questions. One is, should we avoid using phosphoric acid, which is what we etch tooth with, whenever you're thinking about using bonding agents with MDP?
Well, phosphoric acid will probably work on tooth structure, but it's not on zirconia, so there's no point of using that.
Not only I think you can't actually make a difference, but also you should actually really
avoid
avoid
it
because of the phosphoric groups, which will bind to your zirconia, which means it will compete with the binding of the MDP. So certainly you should definitely avoid using it.
So I guess if that question is related to dentine bonding, then if you are using the MDP containing universal bond, then the MDP has been shown, it's kind of a very interesting chemical composition where of course it has the phosphate group, but it has many other arms, so you say. So that makes it not only able to have an affinity to zirconia, but on tooth structure, it actually forms a calcium salt with the hydroxyapatite crystals. And it is claimed that then it helps to stabilize being acid and base resistant in that hybrid layer. So it is very important that if that is what you're aiming for, then theoretically you really need to keep that phosphoric acid away when you do your selective etching. And then you're relying the self-etch component as you rub this primer and bond, like one bottle, all over after you've selectively etched the enamel, and which you haven't touched the dentine area at all. However, it's also very important, I think, in the end though, is to understand that for at least for the dentine, there is ongoing hydrolysis that will happen to that particular interface. It is always good to have a better starting point and more initial stability, or however it can maintain. But it is a biological system where the dentine bed itself is moist, and also this tooth undergo flexure, and that interface of yours, as well as the ceramic material itself. So both that bonding layer and the material will undergo flexure, and with that in mind, it will really help you to choose, what strength of ceramic and how much retention you can really rely on just that bonding interface, or even how to design your bevel or flat top. I mean, all this will come into play in terms of where this tooth is going to be loaded in grip function or canine guided protected, all those things, whether it will challenge that interface or not. But I think we're steering the topic off a little bit.
But
we'll come back.
Bonding is such an important aspect of what we do, but ultimately, it does not replace retention and resistance foam.
No. And I think an important part is even though this MDP grabbed onto different things, and in this, that's why it's been in primers, in bond, in cement now. But it is important to know that, well, if it is just in the cement and is grabbing hold of the zirconia, you can't then just assume, and it is bonding onto this bond or to structure on that surface. It doesn't mean that it has formed part of the hybrid layer unless it was in the primer. So you cannot just assume, oh, I've used MDP here somewhere, that it's going to enhance that stability.
Great. Well, we do have quite a lot of questions, so we'll do these as quickly as possible. So while we're still on the topic of zirconia, so here's a very tricky clinical situation. We'll put you to the test. So this is a clinical situation where the patient has received an anterior zirconia crown. Let's assume it's been bonded perfectly and correctly. Unfortunately, it has suffered a fracture. Now, we don't know whether this is monolithic or whether there's a layered. But anyway, there's been a fracture. So the question here is, can we just prepare that back? Some of it is probably revealing part of the tooth structure, but I'm assuming the mesodisc, the palatal portion is still there, but it's the buccal aspect that's gone. Yes. So can we prepare that and then just do a separate porcelain veneer? So then you're looking at, it's a two-piece ceramic restoration. I've seen those before. So one for the buccal, one for the palatal, and you actually cement them differently. So that's what's, I guess, a concept. That's what it's asking for. Can you leave the mesodistal and the palatal portion of the original zirconia crown, and you just do some sort of an all ceramic veneer buckle?
Well, that's a tricky clinical situations. Well, I would have thought if a zirconia crown has fractured and is anteriorly, then we are faced with possibly some cracks throughout the zirconia material that we may need to consider. Plus, to prepare another veneering layer on top of that zirconia, we also initiating some sort of heat, even though with copious water irrigation, we quite likely will be generating some further cracks in the material itself. I would recommend that you bite the bullet and just remove the whole zirconia crown. We can't guarantee that the bonding of that ceramic veneer will work. We can't guarantee that there will be no further cracks throughout the material. So we don't really know what the clinical outcome. We can't promise a patient who's paying for another veneer a good outcome without ensuring that there's nothing got wrong with whatever's left in the mouth.
So from a best practice point of view, you might as well start from scratch. Theoretically, maybe.
Maybe, yes. I think the other critical issue is when a restoration is fractured, you're dealing with the fracture plane. If you're going to leave the fracture plane and just bond onto it, then that is the direction of whatever force that's caused the fracture. So that's going to be tricky. Yeah. If you prep on it, like that's if you aim no prep and assuming no other fracture in this, there's a lot of assumption. And then if you prep on it, then you could be the operator that is inducing some form of crack. I mean, bear in mind that even as we adjust zirconia, the recommendation is just to use a yellow band handpiece with copious water, and then we have to polish so much, to reduce these crack formation, let alone trying to actually prep on this surface. There are some case study on managing very interesting cases, and I mean these are only case study where you have a two-piece ceramic restoration bonded on a tooth in the aim of not cutting the teeth a lot. But you have to bear in mind that, as artful as that is two pieces of ceramic created fresh and, not being cut on or previously fractured and you're gluing them together. Now, I mean, this is all anecdotal and in theory, so I'm not advocating that people do this restoration routinely, but follow on that particular thought. I guess I'm guessing this particular person have this question. Those will be the things that deter us from saying, go and veneer that, with another piece of restoration, because that would be what my setback maybe. Yeah.
Yeah.
Here's another really interesting question. If a particular tooth has maybe perhaps previously shown certain signs of pulpitis, but the tooth obviously has settled, there's no periapical lesions, and the patient does not want an elective root canal, but your gut feeling tells you that maybe this tooth may need root canal in the future. And on top of that, you're forced to only choose an all ceramic restoration. So PFMs, let's assume, is out off the table. What ceramic material would you use?
I think out of all the ceramic materials, zirconia is probably the better one. And you do want to just have a full zirconia occlusal, just ensure the most conservative endodontists can, even though it's a small hole, but they do want to do with the copious water.
For sure.
Yeah, in terms of preserving the crown.
Yeah.
And sometimes it's not wrong to consider a long-term provisional crown if we in the phase of assessment of that tooth vitality over a short period of time, of course. But
I think in those situations, I know if the audience have actually set us to stick to all ceramic, but I personally would go back to my PFM and leave a gold occlusal.
Yeah.
Only because, I mean, it's not an uncommon scenario, but in a PFM situation, even if you have delamination or chipping of the porcelain, the tooth is still sealed. And then, there are other means, if financially the patient is not yet ready to receive a new crown, there are other means, so long as that tooth is protected, and sealed, then there comes a time where you can still redo that crown at some stage. Whereas if you put in a zirconia, and I would still, it doesn't stop me from considering an all ceramic restoration for this scenario. Doesn't stop me at all. However, I will make it very clear to the patient that the likelihood of them expecting a new restoration when this day comes, it's higher. So if it is with looking at the range of ceramic option and cost and conservation, maybe if there could be even a steric onlay or some sort that they would prefer, so long as it doesn't jeopardize the remaining cervical tooth structure that in the future is very, very critical post-endodontic restoration of the crown, then I have no hesitation upon that, and it will give you abundance of enamel, where as the endodontist access, those periphery is still very much bonded to the enamel, and it will survive that until what it needs next. So I think it all comes down to the patient's expectation of what would to come.
Absolutely. And while we're talking about crowns here, there's another really good question, which is when we're trying in crowns and you potentially maybe adjusting inside the mouth, what are some of the recommendations or tips and tricks you have up your sleeves to perhaps to put some sort of materials inside the crown to help to retain that crown? So while you're adjusting, that crown is not flying off and the patient ends up swallowing it. I'm sure we all had crowns slipping off before, but at the same time, easy to remove that material. Any tips or tricks that you may have? If there isn't such material, how do you go about adjusting crowns?
I actually found fit checker works really well inside the crown. It really helps retain it. Hopefully we'll have enough retention resistance form in the crown structure or in the preparation, and with fit checker inside.
But probably not for a long bevel situation, right?
No. Then that would be your cement.
Yeah. So we're talking about like an all ceramic situation here, where there's that film thickness that's already being put into the die spacer by our ceramic to allow for the cement thickness. Therefore, it's quite passive, and therefore, yes, perhaps using something like fit checker is a great idea. Johnson, because you've done probably more Maryland bridges than all of us combined together, we were talking about a little bit earlier in terms of grooves. Could you talk us through a little bit more about how do you create grooves whenever you're constructing a Maryland bridge, perhaps for both metal frames and zirconia frames?
So for metal frames, Ben has a previous design talk about 245-degree groove there will be the best in retaining this. Basically, very rare for the patient to debone. That's for the metal. But of course, I mean, for the all ceramic situation, you can't do 45 degrees.
No.
So basically, you try to do two parallel at the mesial and distal, and then one rest seat in the middle in the cingulum area.
Right.
Yeah.
And your path of insertion, therefore, is from occlusal.
Occlusal.
Yeah.
But the newest study was showing that bonding to zirconia, you achieve very similar strength compared to E.max.
Yeah, absolutely.
Yeah.
It's quite incredible.
It's very incredible. Yeah.
Really, for a non-etchable ceramic,
Yes.
that you can achieve that.
Yes.
Yeah. There's another terrific question, which is really it should be our one of our summary, which is because we spoke about so much stuff tonight.
Yes.
It's hard sometimes to really grab your mind around it. So I do find these questions really good. It's to say that once you try in your restoration, now it didn't specify what the restoration is. That's why I think it's a great question. Once you try it inside the mouth, how do you reclean that? So I guess we're talking about etchable ceramics,
yep.
And we're talking about non-etchable. So let's say lithium disilicate E.max versus zirconia.
Yep.
After trying, how do you go about cleaning that surface?
Oh, yep. So with E.max first, I personally do not like to etch hydrofluoric acid etch before I try in.
Yeah.
The issue is it is a highly polarized surface. So you basically very easily contaminate the surface. The research shows that if you put a trying paste on the veneers, then there will always be some remnants.
Yeah.
So my protocol is always trying, and then I will start the cleaning process with hydrofluoric acid. Well, wash off any saliva with water, blood, and hydrofluoric acid etch. Wash it off, and then apply the silane.
Yes.
Yeah.
And I suppose it's zirconia?
Same. So I would be washing it with water and like air and water, pretty much.
Yes.
And then sandblasting it.
Yeah, absolutely. Okay.
Yeah.
Well, in a matter of we're running almost 2 hours this evening. It's a little bit longer than expected, but it is a very contemporary topic, and we've covered a lot of ground in a reasonably short period of time. Yeah. Normally, this is perhaps two completely separate different topics. One is looking at ceramics, one is completely just looking at bonding, and we're sort of ambitiously trying to do the two at the same time. So, just before we finish for tonight, what are some of the perhaps as a final take-home message that you could leave with our audience tonight, Agnes?
I think just to remember that I kind of mentioned it before, was the ceramic is great under compression, but it's really terrible to receive any sort of friction. When you think of veneering in cases, we emphasize a lot about preserving tooth structure, wherever possible, bonding onto enamel, or even how to come about choosing the aesthetic outcome. But maybe actually my final remark is you got to look at how the person will look after this restoration as well. Because what a veneer doesn't do is it doesn't really protect the tooth, it is really just a facing. And as a veneer facing, there will be limitations to their lifestyle. I'm not sure about some audiences out there, but with the veneers, I will not encourage them to ever really just bite and snap into apples, because that particular friction itself is challenging. Now this tooth has this veneer facing, is really flexing at that interface, for example. So it could be for these limitations reasons that you got to then think of the actual retention resistance form for the restoration as well, not just limiting to saving tooth structure and aesthetics and all of those. And then it may be because of that, then you really need to look at more like a full crown, but how still will I be able to conserve tooth structure, balancing everything? So really consider what kind of retention and resistance form your restoration truly needs, and take it from there. So how about you, Johnson?
With all ceramic, it opens up a lot of opportunities where they can do very conservative tooth preparation, preserving enamel, like Agnes was saying. We can mask our discolored teeth, you know, and then we can do it in a situation where occlusion is difficult, but it's also very challenging with bonding protocols and how much you do prepare the teeth. So I think it's important to understand and really speak to your technician. So you know, make sure you have a common goal. The last thing you want to is prep the tooth and then send to the technician hoping for the best. Yeah. Yeah. So
but yeah,
a lot
the
of
result
children
doesn't deliver. Yeah.
Yes.
Absolutely. Zoe?
Well, with all these different generations of bonding available and different protocols, it can get a bit confusing.
Very.
And I think at the end of the day, from what we heard from you, Agnes, that was great that you covered it in all like such a systematic way. We do remember that whichever system and whichever protocol we end up going with, it's important to follow the recommended manufacturer protocol, understanding which material you use, is this total etch or contains a self-etching primer and bond, and whether it's universal. So you can have a successful outcome, predictable outcome every single time.
Yeah, 100%. And of course, ceramic, of course, we all know it's a wonderful material with a very wide range of applications. And with the latest developments, whether it's the material itself or the resin bonding system that we have, all wonderful stuff. But these things are not to replace retention or resistance form. These things are not for... Zirconia is a very strong material, but that is not the management of parafunction, for example, per se. You still have to manage all the underlying issues before just go ahead and making these restorations, because true bruxer, that we have treated many of them, if you don't manage bruxers, and it doesn't matter what you put in their mouths, it's probably going to fail.
Except for gold.
Bring on the chrome. Yes. So thank you once again, ladies and gentlemen, for joining us. Please, in the comments box, please do give us feedback. We really want to hear from you, what you like about it, what you don't like about it, and what we can do better, and also what are potentially some of the other topics that you would like to listen to in the future. So let me wrap it up this evening. Thank you for joining us once again. Thank you so much for the entire panel for sharing your time, your wisdom.
Thank you.
And we look forward to seeing you next time. Good night.